Hey, everybody, and welcome to DocTalk. I am Dr. Erin Knopf.
I'm Dr. Corinne Hannan. Welcome.
Today we have a special guest, Stephanie Ginsburg. What up?
Hello, ladies and
Welcome.
world.
We're so happy to have you here. Steph, why don't you tell everyone a little bit about yourself and then we'll dive in.
Okay, happy to. Well, I'm really glad to be here, and I look forward to this conversation around the topic of ARFID and treatment and all the things that go into it. But I am a registered dietitian. I have been one since 2006. And as soon as I became a dietitian, I started in eating disorders. So I've been in the world of eating disorder treatment for quite a long time, most of that spent at higher levels of care. And in 2020, I started my own practice that is 100% virtual still at this point in time, post the height of the pandemic, and based in the Denver metro area. The practice is called Unrestricted Nutrition Counseling and Consulting. And we see a majority of clients who are all ages struggling with ARFID symptomatology or diagnoses. But we also work with all eating disorders, disordered eating, just weight and eating struggles. And I am also co-creator of the ARFID RDs, which is an Instagram handle that is meant to educate and advocate and all the things about ARFID. And I'm also a board member of Very.
Woohoo! We're
Yes,
so lucky to have you.
and thank you for coming today. I've been really excited to have this conversation with you because even as an eating disorder expert myself, I feel like there are really some gaps in my knowledge about ARFID. So I'm really excited to learn from you. So we've mentioned ARFID. You said ARFID's one of your specialties. Let's just start by explaining what exactly ARFID is and what it means.
Absolutely. And I will say, Corinne, you're not alone in feeling like there are gaps of knowledge, even as an expert. And that is like a huge part of the role that I feel like I want to and need to play with fellow clinicians. So glad that I can do that for you. But yeah, so ARFID stands for Avoidant-Restrictive Food Intake Disorder. It is not a new thing. It just is newer as an eating disorder diagnosis since 2013, when the DSM-5 changed it from an infancy and child feeding disorder diagnosis. So this was something that in certain ways was already being managed by speech language pathologists, occupational therapists, feeding therapists, all of that. And so a lot of the work that I have done to help specialize in this is learn from those individuals. So the umbrella term is ARFID. There are 3 subtypes, and each subtype can present individually and independently, but oftentimes there's a mixed type. So it could be any version of 1, 2, or 3. So one of the subtypes is just a genuine and general lack of interest in eating. So it's kind of the lack of interest subtype. Individuals who, may just not have hunger cues or really feel like eating is a burden and would like for it to be the last priority. These are people who wish they could swallow a pill and be fully nourished. Mm-hmm. And then another subtype is sensory avoidance. So these might be individuals who struggle with sensory processing disorder, whether or not that is a diagnosis that they are managing. It could be just a hypersensitivity to sight, sound, smell, noise, and that inadvertently impedes the ability to eat flexibly and eat enough, that kind of thing. And then the third subtype is a fear of aversive consequences, which tends to be a fear of choking or vomiting, fear of food contamination if an individual themselves has a food allergy or a series of food allergies, or someone in their household has one, and so they have to be very careful about what's prepared, what's brought into the house. And so this could be something that they experienced themselves or witnessed in someone else. And it created this fear of, will that happen if I eat that same food? What other foods are similar? What other eating environments are similar to when this occurred? So those are the typical presentations. And again, can be a mix and match. Absolutely.
So that is really helpful for me to ask my next question about ARFID, which you mentioned kind of sensory issues, but I'm curious of what are the most common diagnoses that you see co-occurring in individuals with ARFID?
Yeah, I would say neurodivergence on the whole, right? And there's so many subcategories within that, but oftentimes what we find are individuals who are diagnosed with autism spectrum disorder, who struggle with ADHD, OCD, sensory processing disorder or struggles, anxiety at the core. I would say that typically depression is not as associated as a co-occurring diagnosis or struggle, though it certainly can be.
Thank
If
you.
anything, I would imagine that, depression could be more of a reaction to having this condition, having the diagnosis, having to go through treatment. Sometimes that can be a part of it. I'm curious, when you talk about loss of interest in food or a lack of interest in food, not necessarily a loss, maybe they've always had a lack of interest. What is often misunderstood with ARFID? Because it's not just picky eating, right?
Right. Yeah, it's not. I mean, we all know a ton of people who consider themselves picky eaters and have been able to manage various social situations, are adequately nourished for the most part, and just are more selective with their eating or just have a lot of strong dislikes. And so they avoid those, but it doesn't seem to impact psychosocial functioning. Whereas, ARFID is actually a diagnosis, whereas picky eating isn't. So I think that's a big, point to keep in mind. And I think that, a lot of people think that these individuals don't try very hard, don't care about their health, and are just different. When the reality is up until 2013 and then beyond, realistically, once, the terminology came out and people had more understanding, a lot of individuals were floundering, just not knowing what to do or what to put a label to or what was wrong with them, right?
Totally.
So I do think that it's not just picky eating. It's also not a lesser eating disorder. That's a big point I like to make, even though it's the newer eating disorder on the scene, quote unquote. It's significant, and malnutrition and, growth and development really can be impaired. And the main thing, especially when it comes to emerging adults and adults, is like the impairment with psychosocial functioning. Like really having a hard time feeling like they can go out on a whim to a restaurant and feel like they can open the menu and order anything. There is this new film that's out called Not Just a Picky Eater, and people can rent it on Hulu. We are doing a free screening through the ARFID Collaborative, but it got full in like an instant. So I'm not offering that anymore, but maybe we'll do it again. And there will be a talk back with the producer who has lived experience himself. But the way that they start this film is by having people look at a Cheesecake Factory menu and take note of how many items on the menu they would eat. And we know this is a massive menu, right? And so
massive,
like so massive.
Like 30 pages. It's 30 pages long.
Yes.
It takes an hour just to order. Maybe that's why it takes so long to be seated. They know people have to read the menu for a while.
That's a really good point. I've always wondered why.
And it doesn't even include the cheesecake. I think that's like a separate menu. Yeah.
Exactly. And so individuals who were it's so hard to call normal eaters. I don't even like to say that, but individuals who did not struggle with ARFID symptomatology were averaging about half of the menu that they would enjoy, ordering from. Whereas those with ARFID or ARFID symptomatology were like maybe able to find 3 to 5 things, right?
3 to 5 things.
So if you think about a vast variety of options and such a small opportunity, that makes someone feel really limited and really outcasted.
I have kind of a sub question about that. So in working with eating disorders, people will sometimes ask me, like, what do people restrict the most or binge on the most? And there are kind of types of food that are more commonly restricted or binged on, but in general, any food could be restricted. Any food could be binged on. I'm curious if you find that similar in the ARFID population, that are there particular foods that are more likely to be like that individuals would struggle with more, or could it be any food?
Yeah, great question. Typically, fruits, vegetables, and animal protein are the areas of struggle. Also, in general, combination foods are very difficult, because what is typical with someone with ARFID is the need for consistency within how a food looks, tastes, smells, all the things. And so typically these individuals, especially if there is more of the sensory sensitivity piece of it, they're going to go for Kraft mac and cheese, literally the same every time, right? They're going to go for a peanut butter and maybe jelly sandwich, as long as it doesn't have chunks of fruit in it oftentimes. Mm-hmm. And often, the crust being cut off, because that is a different texture. That's a different use of saliva in the mouth than the actual bread itself. Wow. But yeah, fruits, vegetables, and animal proteins tend to be where the nutritional adequacy lacks. Sometimes that can be because there's poor oral motor skills. And so we often will work on, evaluating whether an occupational therapist is worth coming in to make eating easier. Because if eating is not enjoyable, it's the last priority and it's hard, like how can we actually help individuals move forward?
Yeah, it's miserable and terrifying for people. So that moves into treatment. So tell us a little bit about how you begin to treat ARFID.
Yeah. So there's a lot of modalities, actually. It's been pretty incredible to see therapeutically and nutritionally what has been researched. So there is a CBT, so cognitive behavioral therapy intervention for ARFID. There is actually an FBT, family-based treatment model for ARFID. And so in therapy sessions, those might be incorporated. There is a systematic approach in those ways. And so, individuals can learn how to implement that in their therapy sessions. But from what I do, and I firmly believe, of course, we know with eating disorders, it is super multidisciplinary, hence why we've got all 3 of us here right now, right? But I absolutely feel like the therapist and the dietitian certainly can bleed into one another's roles within working with ARFID, which I love, because then it's not just really stratified and things can be picked up in the next session in the week, right? So what may occur in treatment is a full-on focus of weight recovery, right? Mm-hmm. And that may mean that that's the focus and food exposures take a back seat. It may mean that the emphasis on getting in enough total intake is what takes the precedence, and then eventually get to increasing food variety. Supplements are a very common way that individuals will, help with weight recovery. But also I see like Boost and Ensure and Kate Farms and, not to name drop, but all of these supplements or certain bars as rainy day funds for these individuals, because some days eating just feels too tough, or there is no appetite, but they know they can put a straw in and they can suck it down and they can get nutrition, right? I'm not typically looking for nutritional adequacy from the get-go. I'm looking for enough energy going in to sustain and allow for weight recovery. Thankfully, our food supply is pretty well fortified, and so I don't feel like there tend to be as many deficiencies, even though ultimately we are going to look at the types of foods that they are taking in regularly and see how we might be able to systematically desensitize them. That's the word I like to use more than food exposures, because maybe they're systematically desensitizing to an environment. And so we're doing small steps to acclimate to something that is new or has not been in the mix for quite a while. So maybe it's going into a restaurant and ordering takeout from the counter and sitting and waiting and absorbing the smells, right? Before expecting the individual to be able to sit in that restaurant, be able to tolerate the smells, the noise, the food coming out, hopefully to their liking, right? And then dealing with what's going on within their body that feels dysregulating, and can they then be able to eat? So yeah, and there's also some incredible medications out there that are helpful for increasing appetite in those who are unaware of hunger or don't pay attention to it. And so, yeah, therapeutically, nutritionally, it's about helping the individual do the best they can with what their limitations are. In no way am I expecting someone to all of a sudden become a foodie. Nope. But can we make the eating experience less of a burden?
Well, and I'll
With
just
all
say
of those. Go ahead, Dr. Hannan.
Sorry. I was just going to say that looks so mirrors other forms of eating disorder treatment, because it's first about getting enough as soon as possible, and then about like increasing variety and timing, for example. And in this case, it's also kind of exposure to various environments, which also can be true for other eating disorders. So yeah, lots of overlap, like we've been talking about in our other conversations about these diagnoses.
Yeah.
And totally emphasizes the need for individualized treatment, because there are going to be multiple flavors of how this shows up for someone. And if anything, with all of those interventions and the practices of, helping someone gain skill, gain comfort, gain the ability to have variety, what does recovery look like? In your experience and in your career, what does it look like when someone really is finally in that recovery space with ARFID?
Yeah, I think, and I talk with ARFID colleagues about this, I think it is a blurry word when it comes to ARFID, because I think that, again, it's not from going from eating 4 total foods and being underweight to being weight recovered and eating 100 foods. Like, there is no true marker in that way. But what I seem to sense from a lot of my clients who have made tremendous progress is not necessarily the amount of foods that they incorporate. That surely is a bonus, but it's about the flexibility, cognitive and body flexibility, to be able to manage any eating situation. Whereas someone would have only been able to prepare the food in their own home and eat it with tons of distractions, only up until the point where it starts to change temperature and the texture changes and they lose their appetite and all the things. But can they have another variation of mac and cheese, for example, if that's what they typically, will rely upon? Can they get it at any restaurant? Can they be in any environment and manage themselves and their bodies and their minds when it comes to regular eating, consistent eating, and branching out with eating in whatever way that might look. So I think that these individuals will probably always struggle in similar ways that I think that transition periods are hard for anyone who has an eating disorder. But I think that as long as they know what works for them, as long as they stay on top of regular eating, that's what recovery can look like. Can I feel freer when it comes to the need to eat?
And that too also has so much overlap with, transdiagnostically with other eating disorders, because it really is about how do I recover from the malnutrition and the effects that has on my mind and body, and then how can I make sure I don't ever backslide? So making sure you have that comfort and confidence in safe foods, in meeting your nutritional needs, it's so important. And I really loved actually that example of, can you eat mac and cheese anywhere? Because that actually does open up so much freedom to travel, to go out with family and friends to restaurants, because having toddlers, I know mac and cheese is on every menu. Yeah, it's real.
Right, absolutely. Yeah. And can they be okay with the choices that they make and not feel judged? I think that's another piece to the puzzle.
Yeah, I love the word flexibility. That's really key for me in terms of gauging where we are at with recovery. And I love that Dr. Knopf just mentioned travel, because travel, I think, is a great litmus test for like really testing out your ability to be flexible and making do with what's available without kind of lapsing or relapsing or having on all systems shut down. Like, this isn't necessarily my preference, but I can make do and get my needs met in a way that's going to be flexible and allow me to live my values, i.e. travel, visit family, see the world, etc.
And I will just say, given that there's such a big neurodivergence piece to the ARFID puzzle, is, not helping these individuals not feel like they have to learn how to travel like someone else, but can they figure out from an executive functioning standpoint what needs to be put in place for them to get through the overwhelm of the security line, right? And then being on the plane, and if they usually eat at that time, can they, and flying makes them nervous or their body dysregulated, can they figure out a plan as to when they will next eat? Instead of everyone's ordering a meal and I'm supposed to. If that doesn't work for them, great. We'll make what works for you work, right? And we'll push a little on top of that.
Backup plans, contingency plans, and just and then working to increase that flexibility.
Yep.
So do you have an opinion on maybe some areas that need more research in order to improve how individuals with ARFID are supported?
Yeah, I think that there needs to be more general research when it comes to adults living with ARFID. I think that so often, and I guess going back to the question you had asked, Dr. Knopf, is, a misnomer is that this only affects young kids, right? And the reality is, again, whether there have been individuals who've been struggling with this and then finally got a name put to it once it became a diagnosis and people learned about it, or whether maybe an aversive situation happened in their adult life, like that they are a population who wants to get better and needs to be identified. I think that any correlation between hunger hormones and ARFID is something that's like looming, but could be really helpful in, assessing, and working with these individuals. These individuals have so many GI complaints and concerns. So just more around that as well would be amazing. I'm starting to incorporate pelvic floor work, not myself, but referring out, because that seems to really help ease what is so tight down there that then contributes to more abdominal discomfort before, during, and after the eating experience. I think in general, simple answers, there just needs to be more research. It's really amazing when research comes out about ARFID, but again, because it's so new, there's a lack of research out there. Yeah. I also think, I also think that like how body dysregulation and re-regulation and interoception and proprioception, like how all of these modalities can benefit, and who and how we're helping implement that to make the eating and living experience more, manageable.
So knowing that there is still so much to research and so much to understand from a neurobiological perspective, nature nurture combo too, to send people to find resources and support, because we know even in the ED provider population, it can be hard to find expert providers who really understand the nuances, who are up to date with the most current evidence-based approaches to care. Where do you go? Where can people go?
Yeah, it's an excellent question, and it's partially why part of my day-to-day is training clinicians to feel competent and confident. But what has come out of the fact that ARFID is here, and we need, the clinicians to be there to provide appropriate care. About 11 of us across the country, different disciplines, created the ARFID Collaborative within the past couple of years. And it's a free resource website that has not only information for individuals or anyone connected to someone struggling, it has training opportunities for clinicians as well. And it has a list of providers. It has not been vetted, but we assume if someone has decided to come forward and say, hey, I work with ARFID, I like working with ARFID, I know how to work with ARFID, that they're on that list for a reason. So there's a list of groups that are regularly occurring, support and skills, and food exploration. There's a list of dietitians, therapists, doctors, coaches as well. And so that's where I would absolutely encourage people to go to, www.arfidcollaborative.com. Nancy Zucker out of Duke is doing a lot of research and tends to work with younger individuals, but they have a plethora of information. I just found out about the Peace program. It's out of the UK, and it's a group of individuals, and there's resources for clinicians as well as clients or patients. But it's the convergence of eating disorders and autism spectrum disorders. And again, since that's a co-occurring diagnosis often, I feel like what I've seen on there has been really worthwhile for people. Very treats ARFID. So here we are.
Yeah, we do. Yeah, we do. If anything, it's just so exciting to see what comes in research. We know that, again, transdiagnostically, we need more research everywhere, because eating disorders don't discriminate based off of gender, size, race, any part that can be, a component of identity. There's no discrimination. And yet our research was slanted for so long and so minimal. We really are lacking more robust information to really help us understand the etiologies and needs of these individuals. So it's just so exciting. Thank you for joining us today. It's always lovely to hear from you as an expert. And I just get so excited too about your own career path as an ARFID expert. It's just amazing. So thank you. This has been DocTalk with Dr. Erin Knopf
and Dr. Corinne Hannan. Stephanie, please come back anytime. We'd love having you.
Absolutely. Absolutely. It's been
Love
wonderful.
it.
Thanks, ladies.
Bye.